Question number 5. We have a 71-year-old woman with a past medical history of nephrotic syndrome due to renal amyloidosis presents to your office for a second opinion with the chief complaint of difficulty in swallowing food. The patient states that symptoms have been going on for several years. However, lately they have become more bothersome. She has trouble swallowing both solids and liquids. Many times she regurgitates undigested food several hours after eating. She has frequent heartburn and frequent hiccups. She has lost about 30 pounds over the last few years because of these problems. She was seen by her family doctor who started her on omeprazole 20 milligram daily, but this has not resulted in improvement in her symptoms. She says her symptoms are causing her significant distress and affecting her quality of life, and she would like a permanent solution to her problem. She has a 40-pack-year history of smoking, but she denies drinking or using recreational drugs. These are her vital signs. She's hypoxic. O2 saturation is low on room air. Her BMI is low. We know she has lost about 30-pound weight over the last few years. These are her labs. Hemoglobin is a little bit on the low side. Creatinine is normal. Calcium is normal. Albumin, a touch bit low. Here's the image. You order a barium esophagram. This is the barium esophagram. All right. Here's the question. What is the next best step in the management of this patient? Will you do a pneumatic dilation? Will you do an EGD? Will you do a surgical myotomy? Will you do a botulinum toxin injection, or will you give her isosorbide dinitrate 5 milligram 3 times daily before meals? Okay, so we have a spread here too. The most popular answer is pneumatic dilation. Second most popular is botulinum toxin injection. The least popular answer is EGD. Okay, let's take a look. So the correct answer is EGD, and I will explain to you why EGD is the correct answer. So this is one of the most hallmark pictures in medicine, and this is a barium esophagram, and this is achalasia. And as you can see at the bottom is the bird beak appearance that's characteristic of this disorder. So this whole esophagus is dilated and it's static, it's not moving. All the stuff is accumulating in here. And here is the lower esophageal sphincter going from the esophagus into the stomach. And this lower esophageal sphincter is very tight, which is why there is a tapering at the end of the esophagus. So this patient has achalasia. And most of you chose pneumatic dilation, which is the correct treatment for achalasia, but there is a catch. I gave you two options which are equally good treatments: pneumatic dilation and surgical myotomy. Whenever you get a question in which you get two answers that are very plausible, always think that there is something else going on. Why would someone give you two answers which can both be correct? That means that there is something else going on and both those answers are not correct. I'll tell you the reason why. So the barium esophagram shows a bird beak appearance, pathognomonic for achalasia. The correct next step will be to perform an EGD and rule out the presence of a malignant lower esophageal mass. Never forget that. This patient has considerable risk factors for esophageal malignancy. She's old, she has a strong history of smoking, she has GERD, and she has had a significant weight loss. You cannot just attribute all of that to achalasia. There is a condition called pseudoachalasia, which is caused by a tumor at the esophagogastric junction. It will look exactly like this. If you don't do an EGD, you won't be able to see the tumor, you won't be able to take biopsies, and the patient can die from it. So in achalasia differential diagnosis, always remember pseudoachalasia. If there are considerable risk factors for patient to have an esophageal malignancy, you must do an EGD and take biopsies or rule out a mass. So once you've done the EGD, esophagogastroduodenoscopy or upper endoscopy, pneumatic dilation and surgical myotomy are both acceptable treatments for the achalasia. But proceeding with pneumatic dilation or surgical myotomy now without an AGD is incorrect because she can have pseudoachalasia, and we definitely don't want to miss miss that diagnosis. Botulinum toxin is good in those patients with achalasia who are not considered appropriate for pneumatic dilation or surgical myectomy, primarily because of their comorbidities or high-risk conditions. In this patient, she should be able to have either myectomy or pneumatic dilation once a malignancy has been ruled out. Isosorbide dinitrate may give temporary relief in patients with achalasia by relaxing lower esophageal sphincter and allowing passage of food contents, but it is inappropriate for this patient because of factors mentioned above. We need to do an EGD, rule out malignancy, then once it's ruled out, then we need to give pneumatic dilation or surgical myectomy.